You're listening to a Raconteur Studios podcast.
Hello and welcome to the After Hours Skin Clinic, the place where the skincare conversations never stop. I'm Dr. Emma Craythorne, a consultant dermatologist and host of the After Hours Skin Clinic, here to give you evidence-based, expert answers to the question that everyone's asking. The stuff I get asked all the time, whether it's at a dinner party, whether it's at a picnic in the park, or whether I'm on a walk with my friends. And today's episode is a real special one. It's the first day of Skin Cancer Awareness Month, and we're diving into one of the most important topics in dermatology. And the reason I got into dermatology in the first place, this is skin cancer. What it is, how it shows up, who's at risk, and what we can all do to catch it early. We'll be doing more episodes on this subject over the coming months, so keep an ear out for those. But before we get into that, you know what I'm going to ask. If you do like what we're doing here at the After Hours Skin Clinic, then please follow us or share us with your friends. Let your family know about us, and also you can follow us on social media. It really helps people find out who we are and what we're doing. And of course, we really love hearing your questions, so please keep those coming in. Okay, on with the episode. Today, the brilliant Dr. Ellie Rashid is back with me. Hi, Ellie.
Hello, darling.
So we're going to start right at the beginning. Let's get into it. What is skin cancer?
So skin cancer is an abnormal proliferation of cells, and depending on the cell type that has proliferated, it's got different names. So we normally divide skin cancers into melanoma and non-melanoma skin cancer. And under the group of non-melanoma skin cancer, we have a basal cell carcinoma. So that's a proliferation of these basal cells in the skin. And we have a squamous cell carcinoma, proliferation of the squamous cells in the skin. And then a melanoma is a proliferation. So this is like an uncontrolled division with a proliferation of those pigment cells in the skin. So that's the broadest way that I normally categorize my skin cancer into those two big groups.
So a cancer essentially is whenever there's this abnormal cell that keeps dividing and doesn't stop dividing and ends up destroying other things in its midst. And really, whatever that cell type is that's gone array is how we then classify the skin cancer. And so we'll get into breaking up these different types of skin cancer and trying to identify what they are. But there are some people who are just generally more at risk of skin cancers. I used to almost, whenever we did the skin cancer clinic, and I would go out and call the person's name. This is a 2-week wait clinic that we would do in the NHS, where it was a huge long list. You know, you had this massive list of patients. Somebody had noticed a spot or whatever on their body. Been to see their GP. The GP thought it might have been a skin cancer, so refers it up to dermatology. And you would call the patient in and then examine them to find out whether this was a skin cancer or not. And I loved that moment of going to pick the patient up and walking along the corridor with them, sussing out as I was walking what the rest of their skin looked like, what their job had been, how much evidence of sun damage they had. So by the time they got to the room, I had a fairly good idea of whether they were high risk or not. So should we go through what makes somebody high risk?
Yeah, so things that make someone high risk is their skin colour. So those that have white skin, that might be freckly, that might have red hair, light coloured eyes like blue or green eyes would be more at risk compared to someone who's got melanin rich skin. So this is black skin. But that's not to say that people that have black skin don't get certain types of skin cancer. And then I guess the other things that you can normally notice on someone is, for example, if someone has no hair on their head, then you know that their scalp has had a lot of UV radiation, a lot of UV exposure, and the hair that's normally protective to protect the skin on the scalp is not there. And therefore, someone that's not got hair on their head might be more at risk of developing certain types of UV related or sun related types of skin cancer on the surface of their head.
And you can almost see by somebody's face, well, you can totally see by somebody's face how much UV exposure that they've had over their lifetime, because you see this in the form of red blotches or blood vessels or sunspots, so the brown spots, or these actinic keratosis, which are slightly crusted areas in response to sun exposure. So you can see all of those things already. And then, of course, somebody who's already had a skin cancer themselves, or somebody where skin cancer runs within the family. And particularly if you have a first-degree relative who has had a skin cancer, then you're more at risk of developing a skin cancer as well. So that's really the group of people who are most at high risk. But then there's also people who have specific genetic syndromes that put them more at risk of having a skin cancer too. But you would typically know that you have that.
Yeah, you'd know that you have it. And also the risk of melanoma skin cancer is really relevant. If you've got a first degree relative that's got melanoma, then that puts you at high risk. But things like these sun-related types of UV-induced skin cancers, like the non-melanoma skin cancers, really, even if you have a first-degree relative that has had like a basal cell carcinoma or squamous cell carcinoma, if you are someone that has been really strict with your UV protection, really the only thing that you've inherited in terms of the risk of those UV-related types of skin cancer, like the non-melanoma skin cancers, would be that you've inherited a similar sort of complexion. But if you're mixed race, for example, and you've got quite pigment-rich skin, then you're probably less at risk, even if like your white-skinned mother or father might have a history of basal cell carcinoma or squamous cell carcinoma.
Yes, because you're naturally protected. Your cells are naturally protected because of the skin color. So it's melanin essentially that is protecting our DNA. So our melanocytes, which are the cells that produce pigment, they make melanin and it's passed along to the top of the skin cells or the keratinocytes. And it sits right on top of the nucleus like a little cap, like a little sun hat, protecting the inside of the nucleus from DNA damage from ultraviolet radiation. And we all make different types of melanin. So there's really something called eumelanin or pheomelanin. And that's why whenever you said about somebody who has red hair, that tendency is to make pheomelanin, which is just not as protective as the browner kind of melanin. And hence then more damage is likely to occur. And what's also interesting is even once that damage has occurred, the pheomelanin is not a very good antioxidant like the eumelanin is, and therefore it doesn't repair the damage in quite the same way as well. Let's think about how we actually get a skin cancer, it being related to ultraviolet radiation, because we have our genetics that put us at risk. And that's some of the things that we've just described. But the vast majority of skin cancer is because of ultraviolet radiation. And what happens is there is a chromophore in our skin, and the chromophore in our skin picks up the radiation that comes from ultraviolet, and that essentially damages the DNA. It causes a single point mutation, and that mutation then gets repaired by our DNA repair systems, but actually it can leave over multiple times more and more of these little spelling mistakes. And whenever that then occurs in how the cell is then replicating and changing, if that becomes a problem, that is when the skin cancer then occurs. So you typically have to have multiple hits of these mutations. We call them UV signature mutations, and you have enough of these, and that is what then induces a skin cancer because of ultraviolet radiation. But of course, there's other things that cause these mutations as well that can result in skin cancers.
Yeah, when I think about people at risk of skin cancer, I always think about the cumulative risk. Like when you'll keep having these hits and these mutations happening, then the cumulative risk of those happening is what increases your risk of developing a skin cancer, rather than, a one-off sunbed someone might worry about, like if I massively increase my risk. But it's not really the one-off episode that's going to be the real risk. It's usually that cumulative, repeated, having regular sunbed treatments all the time, which I think should be banned in this country, by the way. But it's that sort of risk that we think about.
When I worked in Glasgow, they had the tanning beds. Actually, they weren't tanning beds. They were tanning, these toilets that you can get on the street, like these cubicles where there's toilets that you can go into.
Yeah, like a portaloo.
Like a portaloo
thing.
Well, in Glasgow, whenever I worked there, they had exactly the same thing, but they were sunbeds. So you could go in and have a stand-up sunbed. Just anybody could.
God.
That's true.
Well, I had a patient recently who was 16. Well, actually, she was even like 15 or 14, and she was extremely tanned. I said, how are you so tanned? And then she said, I use sunbeds like twice a week, have been since I've been 14. I said, is there not an age restriction? She said, yeah, just say that I'm 18 and have my sunbed.
Yeah, and that is just what happens.
Just
Although there are regulators who are meant to go out and check, but I mean,
That'd
who
be
can check all the sunbed places?
Yeah, it's impossible.
You would have thought that the public health message would have got out that it is going to age your skin, but then at that age, you just don't understand what risk really is and how that's going to affect you in the future.
Yeah, completely. When you're young, I guess you just don't really understand the risk. But I think it's really up to like your parents when you're that young to really instill in you that you shouldn't be having a sunbed twice a week at such a young age.
Are you joking? At 15, your parents telling you not to do something, you're going to immediately do it. You're not allowed to do that. Okay, seeking the first opportunity to do that.
I'd call the sunbed place off immediately. I'm like, you're not treating it legal.
I mean, there was a real trend in the 80s of having sunbeds and everybody used sunbeds. And then it kind of went out of fashion as well. But also the risks were then really noted. You know, the WHO said that this is a class 1 carcinogen in the same way that smoking can cause lung cancer. This can cause skin cancer. And so it kind of went very much out of fashion. But I do see it creeping back in again for younger and younger people, which is such a shame because there are such good fake tans that you can use if you want to be tanned.
I literally had this conversation. I was like, why aren't you just using a fake tan? She's like, oh, it's too much work.
Oh, but it's like you've got to go
I
and
know, I know.
lie and like it's
know,
horrible.
I know.
I don't like it. No, not at all. I can almost hear the little skin cells screaming.
Yeah.
No, get away.
Save me.
So let's break it down into the different types of skin cancer. We will start with the most commonest cancer, actually, not even the most commonest skin cancer, but it's the most commonest cancer in the UK, and that is a basal cell carcinoma. So a basal cell carcinoma is a type of skin cancer that is derived from the basal layer cells. And that is, if you think about the cross-section of the skin, the bottom of the epidermis, that is where these basal cells reside. And they go all the way down the hair follicle, at the lining of the hair follicle. And they essentially are these precursor cells that go on then to make these keratinocytes thereafter. So these basal cells sit and they take up the ultraviolet radiation, and with enough mutational hits, they'll turn into a skin cancer. Now, what this looks like is it used to be called a rodent ulcer in the past. Do you remember you would tell people you've got a rodent ulcer?
Yes, and people would relate to that.
Yeah. And say, oh, good, I don't have a cancer. I was like, well, actually, it's a cancer. Well, why did you call it cancer? So now we do call it a cancer. But I always say to people, this is not something that is going to go anywhere. This is not something that's going to spread anywhere else or cause problems around the rest of your body. It is something that stays where it is, and it gradually and slowly gets bigger. And the best thing to do about it is to do the thing about it when it's small, so that you have a much smaller scar or treatment area as a result of it. Because catching things early with the right treatments is key, and particularly with a basal cell carcinoma, so that you don't have a big scar.
Yeah, so they take different forms, but the most common form is this rodent's ulcer appearance, where you've got this pearly, sort of smooth, round edge to it, and it looks like a rodent has gnawed away at this little bump on the skin, so it's got a little ulcerated dip in the middle, and then you can see these visible blood vessels on the surface of it. But then you can also have it where it looks like red and scaly, and that's a superficial form of a basal cell carcinoma. So it can look different. Some people, you can't really see where the boundaries are. You don't really get this sort of raised, pearly edged border, something called a morphaic basal cell carcinoma. So there are just different subtypes of it, but the most common is the rodent's ulcer appearance of it. And I normally say to patients, even though it comes under the category of a skin cancer, this is not something for you to worry about. So it's not something that will take a day of your life, won't go anywhere, won't spread anywhere, but it's just locally, very gradually it grows, and it further ulcerates, it bleeds, it just causes a nuisance. So the quicker you do something about it and sort the problem out, the better.
Exactly. And the things to do about it really depend on what kind of basal cell carcinoma it is. So as doctors, we divide these basal cell carcinomas up into, just as you described, they're either superficial, so these dry scaly patches, nodular, where they look like the rodent ulcer, or they're morphaic and they look a bit more like a scar actually, and you can't really see the boundaries. And depending on what type they are and depending on where they are on the body really determines what the best treatment is. So if we think of one, say, for example, it is on the face, and it particularly is one of these higher risk ones, so these scar-like ones called morphaic, or even some of the nodular ones. But if they are in a high risk area of the face, so near the eyes, the nose, the mouth, then The first line treatment that we think of as gold standard is something called Mohs micrographic surgery. And that is a surgical technique that's done under local anaesthetic while you're awake. A little bit of anaesthetic is put under the lesion, and the lesion is removed with very narrow borders, very, very tiny, just a couple of millimeters. It's then looked at under the microscope, and it's looked at all the way around and all the depth of it. And it's looked to see whether it's got it all out. And only when it's all out, then does it get stitched up. So that is considered Mohs surgery. It's the best for conserving the normal tissue, and you end up with a better cosmetic outcome. So that is really the first treatment to be considered if somebody has one on their face, particularly if one is in an area like the eyes, the ears, the nose, the mouth. The most important thing to think about. The next thing to think about is just cutting it out, because Mohs surgery is really expensive to have done. So it costs the NHS a lot of money, so they can't do that on every case of a BCC. So the next treatment then is just to cut it out, and you would cut this out with a 4mm margin. So again, done under local anaesthetic, removed and stitched up immediately. You don't have to wait a couple of hours to get the pathology back. You just get it stitched up straight away. And then you go home and wait to find out whether it's all been removed, which you find out a couple of weeks later. And then in some cases, you can just inject it and you can scrape it away, a process called curettage and cautery. And in some cases, if it's these very superficial types, you can use creams on them. And the two creams we typically would use would either be something called 5% imiquimod or 5-fluorouracil. And these are topical chemotherapy or immunotherapy treatments. And you apply these to the lesion for around about somewhere between 4 to 8 weeks to get an inflammatory response to clear them. And then, of course, there's also radiotherapy, which can be used on any of them. But the radiotherapy requires a lot of visits up to hospital. It's usually around about 12 treatments of radiotherapy over a 3-week period. So that can be a little bit tiresome and cumbersome. But for many people who don't want to go through the surgical side of things, or they might have a larger lesion that's really troublesome and problematic, then radiotherapy might be a good option. So they're the main treatments that we would think of.
Yeah, just a few things to say. So before you're thinking about Mohs surgery, this microscope-assisted Mohs micrographic surgery, you'd normally do a skin biopsy first. So take a sample of it to confirm the diagnosis. And if you're thinking about just going straight for surgery, then obviously you would get your histological diagnosis at the time you're removing the whole thing. But before the Mohs surgery, you'd normally do a biopsy first. And then if someone's got this morphaic BCC where you can't really see the boundaries very clearly, then that's often best managed with Mohs micrographic surgery, because it's really difficult to delineate where it starts and where it ends. And then that 4mm margin that you've been talking about is really difficult to assess. So to have that microscope assisted surgery is best practice for that type of BCC.
I always feel so biased whenever I'm given this, because as a Mohs surgeon, I think that everyone should have Mohs. Yeah. So I'm always very biased whenever I just say Mohs is best. But truly, Mohs is best for removing these with the smallest boundary possible, so that you've got a better outcome in terms of cosmesis. But also, you're reassured at the very time of surgery that it is all gone before it's even closed up. So that's why. And so particularly for the head and neck area. Go Mohs surgeons.
I mean, I'd want Mohs if I had a basal cell carcinoma.
Of course. Okay, so shall we move to a squamous cell carcinoma?
Yes, let's do it. So squamous cell carcinoma is a abnormal proliferation of the squamous cells that we have within our skin. So again, in that top layer of skin, and it's usually sun related. So UV exposure is definitely one of the biggest risk factors for developing a squamous cell carcinoma. Now, squamous cell carcinomas, they grow a little bit more rapidly, so they can come up quite quickly. They normally look like these red ulcerated, sometimes bumps on the skin. You can get a variant of it, which is a superficial form, something called Bowen's disease, which is a squamous cell carcinoma just in that very, very, very top layer of skin. So that can look like a red scaly patch on the skin. So sometimes it's a little bit difficult to delineate whether it's an SCC in situ or a Bowen's disease, or whether it might be like a superficial basal cell carcinoma. But squamous cell carcinoma, the one that looks more bumpy or nodular, you normally can tell from the rate of growth. So it comes up quite quickly, develops quite quickly. And these ones you do have to manage proactively and quickly, because they can potentially, depending on how long they've been left there for, they can potentially spread usually to the local lymph node. So if it's on your head and neck, it might spread to the lymph nodes that we've got in our neck. And they're, again, normally more at risk of places where we get most UV exposure. So the head and neck, backs of the hands are another common area that people can develop a squamous cell carcinoma.
And they really are a very difficult thing to predict, because if somebody says to me, I've got a squamous cell carcinoma, what does that mean? Or I'll be on a walk at the park and somebody will say, oh, my dad's been diagnosed with this. What does that mean? And it actually can mean one of two very, very different things, because depending on the certain factors that you see within the squamous cell carcinoma in terms of what the size of it is, how deep it goes, how well, what we call differentiated, in other words, how like the original cell it actually is. All of these factors are really important, because some of them, in fact, the vast majority of them, behave just like the BCC that we described, and very rarely does anything. It just stays there and will gradually just get a bit annoying and not really do much at all. But a smaller cohort of these actually are very, very dangerous, and they can spread quite rapidly and can cause as much harm or worry or concern as something like a melanoma, which everybody is instantly frightened or worried about. But these very high risk squamous cell carcinomas are just as dangerous. So you get two real spectrums with SCCs.
Yeah, it completely depends on what you see under the microscope once you've removed the squamous cell carcinoma. So the result of that histological assessment, normally then you can prognosticate a patient as to whether it's a high risk squamous cell carcinoma or a low risk squamous cell carcinoma.
And to save going through the treatment options, we can pretty much say it's exactly what you just heard for BCCs. So Mohs micrographic surgery, cutting it out, something called excision, curettage and cautery where it gets scraped away, or radiotherapy. Or for these very superficial Bowen's disease or SCC in situ, you can use the topical chemotherapy agents like 5-fluorouracil.
Yeah, and for both superficial basal cell carcinoma and a superficial Bowen's disease, SCC, you can also use cryotherapy, so to freeze them as well. Probably a less reliable form of treatment, but if someone didn't want another type of treatment, then that's a potential option that you can go forward with.
Yeah, definitely. I just don't like leaving the white marks that it leaves on the head and neck. That's the reason why I don't like cryotherapy.
Yeah, but if you've got on the back of the hands.
Yeah, exactly.
So let's move on to melanoma.
So a melanoma is a type of skin cancer that derives from these melanocytes. So they were the cells that are making the melanin, trying to protect the rest of our skin cells. And they usually present as brown patches on the skin. So people think of them looking a little bit like a mole, and the mole itself has got certain characteristics about it that make it stand out. So quite often there is asymmetry of that mole. So instead of being a nice regular outline, the outline of it can be scalloped or kind of curved as it goes round. The lesion itself is asymmetrical, so one side doesn't quite match up with the other. There might be lots of different colours within it. And although we often say that it has to be a big lesion, melanomas, they start off super small and they get bigger. Most melanomas don't actually arise in a mole. So people will say, I'm keeping an eye on my moles, but actually most melanomas arrive not related to a mole at all. It's a new finding within the skin, although sometimes it is a mole that's been there already and then it starts to change. But I think the key feature to understand is it's about that change of the lesion. So the other thing to know as well is that they don't just have to be brown. Melanomas can present and they can be pink. I often think, whenever I think of an amelanotic melanoma, which is a melanoma that doesn't have any pigment in it, the pinkness is a bit like a strawberry milkshake, that kind of a pink. And occasionally it can present as a pinky purple raised nodule on the skin. So all of these different types could be melanoma. which is very difficult then to explain to somebody what exactly to look out for. And I think the key is looking for something that's changed or is different or is new and has not gone away after 6 weeks. So that would be the key things to look out for.
Yeah. I normally tell patients to just think about the A, B, C, D, E. So just for simplicity, A is for asymmetry, exactly as you've described. B is for the border. So if it's got like a jaggedy border, if it's got a smooth outline, or if you can't see where it starts and ends. C is for colour. So if there are different colours within it, like dark brown, black, red, pink within the mole. D is for diameter. So that's usually that it's enlarging or changing its diameter, it's getting bigger. E is for evolution. So has it started off being flat and now it's bumpy, or was it raised and now it's flat? I normally say to patients, even though I give them that advice to like think about the A, B, C, D, E, if you're worried about something, the best thing to do is to be reassured and not have to think about it again, or then to do something about it. Because with all the will in the world, it's really hard for people to be able to accurately assess every single one of their moles and be able to identify if something new has proliferated in an abnormal way on their skin. Like they just might not notice.
And I mean, there is that old adage that we always say, and you're not a dermatologist until you've cut out something that you think is a seborrheic keratosis and it turns out to be a melanoma.
I know.
Have you done that?
No, not yet.
Oh, I have. Sorry, I thought you were a dermatologist.
The ones that scare me are the amelanotic ones. So the ones that don't look brown.
Yeah,
The ones that are pink. I always worry about those ones.
I am quite up on the amelanotic ones because I see a lot of amelanotic melanomas. I am in a slightly weird
Biased
cohort
group.
of dermatologists, that sees quite a lot of these amelanotic ones. So those are the ones that I've kind of got. But they're the scary ones because they do look like a little patch of eczema, or they do look like a very superficial little scar almost in some
Whenever we have
cases.
like a teaching session on skin cancer and they put up all the slides of things that you would not think is a skin cancer, but it has turned out to be a skin cancer, I always look at these slides and I'm like, oh my gosh.
And then your rate of excision for actual melanoma goes like crazy.
In the weeks that come after that, I'm like, we're cutting it all out. Out. Nope, don't like the look of that. Don't like the look of that.
But I think that is really important, isn't it? Because what you don't want to do is, because some people have a lot of funny looking lesions on their skin. And that's what we think of them as, just funny looking lesions. And what they don't want to have to happen to them is lots of scars just because they have moles or other lesions on their skin that look a bit different. And, you know, we do see that. I'll see somebody in clinic and I'll say, okay, so how many moles have you had cut out? Oh, 52. And how many of them were cancerous? None. You don't want that either. So it's trying to get that exact balance, isn't it? But I think the key thing is with melanoma is it is directly related to the depth of the lesion. So what I mean by that is if somebody has a thin melanoma, then that means it's usually been caught early, and usually the outcomes are very good for the person that has a thin melanoma. If somebody has a thick melanoma, then that is exactly correlated to a worse outcome. So when people say, oh, if you're worried about something, you should seek help early, this is really the point, that this is incredibly important. If you're worried about a mole or a spot on your skin that's changed, getting it early really is the difference between a good outcome and a poor outcome. So thin melanomas are associated with a much better outcome than thicker melanomas. And I think that that's a very important message, which is why there is so much about examining your skin and mole mapping of the skin. And actually mole mapping can be very difficult if it's on the back of your body, isn't it?
Yeah, so mole mapping used to be taking these 2D photographs of people and mapping all of their moles. And when we would see them back in clinic, you would look at the photograph, look at the person, be like, oh, yep, that looks new or that looks different. And then you could have a baseline to compare against. But now with the evolution of technology, we now have this mole mapping machine which actually recreates this 3D sort of avatar of you and all of your moles. And then you come and have your repeat mole mapping done a year later. And then the software can compare all of those moles against each other to see if there's more pigment, less pigment, or any new lesions that may have arisen. It still is a research tool. So the gold standard is still that you would see your consultant dermatologist and they would assess your moles to assess whether they're fine or whether there's anything that needs to be cut out or anything that needs to be biopsied. But it can be a really lovely advantage to be able to use that in addition to that gold standard to be able to see if something might have come up that you need to do something about.
Yeah, I mean, it is a real game changer. It's crazy how many different things it always picks up. And then the year later, watching what has changed. And obviously the vast majority of everything, the change is nothing to worry about, but it picks up everything.
Yeah. And one thing that I normally get asked by patients is if they have a mole that I'm worried about, could I not just take a biopsy of it, like a small sample of it, to assess that under the microscope to then see if the rest of it needs to be removed? And actually, I normally say that if you have a mole that I'm worried about or concerned about, the whole mole needs to be removed, normally with a 2mm edge of normal skin around the entirety of the mole. And that way, the entire mole can be assessed under the microscope so that we're not falsely reassuring you because we might have just sampled the wrong part of the mole. So the safest thing to do is just to remove the mole in its entirety.
And the only exception to that, I would say, is whenever somebody has a condition called lentigo maligna. Now, lentigo maligna is considered a pre-melanoma, so it's a pre-cancer, and it occurs usually on the face and usually of older people, although I'm seeing it in patients in their 30s and 40s now because of this overexposure to ultraviolet radiation. And these are usually very flat, brown marks, and they can get really quite big. So in those situations, it's okay to sample the worst part of the lentigo maligna to get the diagnosis, because if you were to try and attempt to remove that entire lesion, often it represents half a cheek, so you certainly don't want to do that. And I suppose it's a point to note that lentigo maligna is considered a precancer. But I think it's important to understand the biology of these lentigo maligna, because sometimes people will rush in and think, oh, it's a precancer, I just have to get the whole thing cut out. And quite often patients are in their 70s or 80s, and these lentigo maligna carry such a small risk of changing. And I'm talking about if you're 75, for example, your risk is only about 1.9% of it changing to become a melanoma. And certainly there are other options like topical treatments with imiquimod or even radiotherapy, which isn't as good as the imiquimod probably, to use instead of surgery, because surgery can be, as you can imagine, removing half of your cheek skin, rather devastating. So lentigo maligna, yes, is considered a pre-melanoma or a pre-cancer, but the risk of rate of change really needs to be assessed and thought through with the patient before just jumping into surgery. What are our key takeaways?
So my key takeaway is just to have an awareness of your moles so that you can then identify if something that's arising on the skin might be new or might look different. So just to have an awareness, maybe take some photographs on your camera phone, and then you can revert back to it and look at it and think that just looks different to how I remember it looking.
My takeaway would be is have someone else just have a look at your back. You know, if you live with somebody, ask them to have a quick look at your back and see if there's anything on your back that stands out. My dad stayed at my house, this was probably about 8 or 9 years ago, and he was going from our bathroom into his bedroom and he just had a little towel round his waist. And I was like, Dad, what is that on your back? And it was a melanoma. And so it had been there probably for about a year or so, and nobody had actually noticed it or seen it. So I would say just ask somebody else to have a scan of your back. If you do, it's really hard to see your back.
Your daughter's a consultant dermatologist.
Oh, he didn't point it out to me, obviously. I was like, what's that in your back? Oh, my back. Yeah. Well, it's actually melanoma.
And I guess the main take home would be to put your SPF on.
Put your SPF on, particularly in your face, because these BCCs and SCCs that we talked about, where surgery is the answer for removing them, you're then going to end up with scars on your face. So in order to not get the skin cancer, putting on the SPF is key. Or seeking shade, wearing your hat, avoiding that direct, particularly burning sunshine, but also the cumulative sunshine. So even just little bits at a time is really important. And like, just never use a sunbed.
Ever.
Ever. And that's a wrap on this special episode of the After Hours Skin Clinic, where we've done a quick fire whirlwind visit through some of the more common kinds of skin cancer. And in a future episode, I'm going to be joined by Jessica, who's going to share her own skin cancer story. And she's also campaigning to axe the SPF tax. So I'm looking forward to hearing her story. If there's one thing we hope you take away from this episode, is that early detection really can be skin-saving or even life-saving. And the earlier we catch these things, it's always the better the outcomes. So even simple things like understanding your own risk and checking your moles regularly can make a massive difference. If you found today's episode helpful, then please do give us a follow, share this with your friends, or share our stories with your family. And don't forget, we love hearing your questions, so keep sending those in. You might just hear yours featured in an upcoming episode. Thank you for joining me, Ellie.
Thanks so much for having me.
And thank you, my lovely listener, for joining us. Until next time, take care of your skin, wear your SPF, and we'll see you next time on the After Hours Skin Clinic. As always, this podcast is for informational purposes only and is not a substitute for medical advice. Please consult your healthcare professional before making a change to your treatment.